Afternoon, everyone. I'm Smita. I'm one of the GPs local and with special interest in cardiodiabetology and pediatrics, and making a smooth transition from what Roxana has presented into the postnatal check. Can everyone hear me and see my slides? Yeah. Can't see the chat box either, so yeah, I can see it now. Okay, thank you.
You should see this as a pop-up coming at the bottom, all right?
Yes, that's fine, thank you. Okay. So what I'll be covering in today's presentation is mainly about these things. So quick background, physical examination at 6 to 8 week check, review of the development, a bit of health promotion, maternal health, and postpartum contraception. So there is this NHS newborn and infant physical examination screening program, which is done within 72 hours of birth and postnatally at 6 to 8 weeks of age. The purpose is to screen for abnormalities, monitor their developments, and provide support for worried parents. And the 4 main screening elements that we look at are the eyes, heart, hips, and testes. And these are the prevalence of what are the abnormalities which we normally find in terms of the prevalence of the conditions for all these 4 conditions. So what happens to the babies who are born at home? You can just put anything in the chat as to what happens if they don't have a hospital birth and they have a home birth. Who does the postnatal or the neonatal newborn examination? Okay, so every baby born in hospital, once they are discharged home, for the first 10 days, they are under the care of the midwives. And any home birth, if the midwife is in attendance and they are trained to do the neonatal check, they can do the neonatal check for all home births, or it can be done by the GPs. At the same time, can the parents decline a neonatal or infant physical examination screening? Anybody, you can share it in the chat. Parents have the right to decline all or part of the screening. If they decline, then it should be documented in the national IT system and communicated to the GP and the health visitors.
It says there could be a safeguarding concern. There's a response there.
Yes, thanks, Megan, for your answers. Obviously, if it has been offered to the parents that this is a screening program and the parents decline it, it's their right, as long as everything is documented and passed on to the relevant healthcare professional in terms of GP, health visitors, primary care health record, it should be okay. And it will be followed up in terms of if any concerns arise in future. That's a very good thing to flag up. Following on from this, when we do the neonatal or the postnatal examination, get a quick history, get the parental concerns, baby's medical history in terms of fetal, neonatal, infant, whether the baby has passed meconium or urine. This is mainly relevant for those in the neonatal examination. As per NICE, we do a physical examination. How I do it is to keep a head-to-toe approach. So that minimizes the chance of you missing certain things. So start from the head, look at the scalp, feel for the fontanelle, check the head circumference. Further down, look for the eyes, look for the ears, nose, look for the palate, feel for the shoulders, clavicle, look at the digits and palms, listen to the heart, listen to the lungs, palpate the abdomen, further down, genitalia, testes, femoral pulses, look at the legs and the feet. Normally, we should leave the hip examination towards the end because it can be a bit uncomfortable and distressing to the babies. So do your Barlow and Ortolani at the end. Another tip could be, once the baby is nice and settled, listen to the heart, because it will be easy for you to appreciate if there are any murmurs. Otherwise, once you undress the baby can get distressed, crying, and then you're not able to appreciate the heart sounds or the murmurs. So we have a 6-week-old baby girl here who has a normal red reflex. The purpose of red reflex is you can type your responses in the chat box. Yeah, there are a few responses I can see. Okay, that's right. So red reflex is what we see through the ophthalmoscope. It is the light reflected from the baby's fundus to the examiner's eye. Absence of red reflex can be pathological in terms of congenital cataract or serious life-threatening condition as retinoblastoma. Just bear in mind that babies with a slightly darker skin can have a slightly pale retina in terms of peach colored. So don't feel that that is not a normal red reflex. That is absolutely normal for such babies to have a slightly pale retina. Examination of the eye, what are the risk factors? If they have a first-degree relative with congenital cataracts or the other eye conditions, genetic syndromes, the baby has a significant port wine stain, and when it involves the eyelids, that can be significant as well. Premature infants, and if mom has been exposed to viruses antenatally. So these are the risk factors. We assess the eye in terms of all of these. The eye movement, fixing and following is mainly for the postnatal, so the 6 to 8 week check. So anyone with this diagnosis, you can put it in the chat box. Let's focus on the eyes, yeah. Yeah, there are some responses. Absolutely, this is a congenital cataract. Okay. What about this? This is a neonate, which you can see a bit of redness of the eyelids, red conjunctiva, and Caroline has very clearly did mention about in her chat, in her presentation as well. Absolutely right. So there is conjunctivitis. Yeah, Megan, that's right. So most likely it can be just a normal viral or bacterial conjunctivitis. But in a neonate, we have to be careful and we have to rule out a chlamydial or a gonococcal conjunctivitis. So all you have to do is take a swab, start them on treatment with chloramphenicol, and just wait for the swab reports and then change your antibiotics based on the sensitivity. And what
there was a response which you may have seen, ophthalmia neonatorum.
Yes, that is a condition which does we do see, but this is conjunctivitis, Alexander. Okay, so going to the next one. Perfect, yes, it is coloboma, that's right. Okay. So once we've done the screening for the eyes, what are the referral pathways? If the screen is negative, the child is transferred to the Healthy Child program, and then they have the next screening at 4 to 5 years of age. If the screen is positive following a newborn examination, they get assessed by ophthalmology at 2 weeks of age. If it is positive at 6 to 8 week examination, then they get an assessment by ophthalmology at 11 weeks. So about 2 to 3 weeks after it's found out.
So there's a question about what is a coloboma?
It is a neonatal development abnormality of the eyes, where you can see the black dot where I can go back to the slides. Sorry, I'll put my answer in the chat. Is that okay? So moving on, we've got an 8-week-old baby girl whom you find to have a cardiac murmur. The tone is normal, good hydration, good color, and the rest of the examination is normal. She's thriving very well. What should you do? Anyone? Okay. That's right, yeah. So any baby, any cardiac murmur, and even if the child is asymptomatic, they need to be referred to pediatric outpatient for an echocardiogram. If cardiac murmur with symptomatic infant, in terms of being breathless, cyanosis, absent pulse, femoral pulses, poor feeding, poor weight gain, tachypnea, tachycardia, you have to speak to the pediatric on-call team for same-day assessment. Why it is important, the heart examination, because congenital heart disease is the most common malformation. Early detection, and that improves the long-term outcomes. Risk factors are family history, genetic diseases, maternal antenatal exposure to viruses or drugs. As you would do in an adult, look for cyanosis, ventricular heave, respiratory distress, tachypnea, apex beat, listen for murmurs. As Megan pointed out, innocent murmurs are very common, but they are of low intensity and they are localized to a small area of the pericardium, and there will be absence of other signs. But all murmurs should be referred to specialists for assessment. So moving on, these are the lesions that you will be able to pick up, the neonatal or the postnatal examination. Only the large VSDs, they present with heart failure, and the different types of murmur for each of the condition. If you're not able to remember or differentiate what the murmur is, for all practical purposes, in a neonate or a postnatal examination, all heart murmurs are systolic, except PDA, where you'll get a continuous murmur. So as long as you are able to identify the murmur that is more than expected from the neonatal check. Then going back to, let's listen to some of the murmurs, hope it plays. So that's the VSD murmur. Okay, this is a continuous murmur. And an ASD murmur. Okay. Moving on from heart, we come to the hips. So we have a 6-week-old baby boy who's being examined at the postnatal check. His legs are of the same length, but he's got an asymmetrical leg crease. You perform an Ortolani test and feel a clunk. Which of the following is correct? Just put the alphabets in the chat box. Okay, so this is developmental dysplasia of the hip. Why is hip examination important? Because we have to diagnose early and intervene early so that we improve the health outcomes and reduce any unnecessary surgical intervention. If any unstable hips that remains undetectable, there may be a need for complex surgeries and long-term complications in terms of impaired mobility, pain, osteoarthritis of hip or back. What are the risk factors? Is anyone with a first-degree relative with hip problems in early life, breech presentation at or more than 36 weeks of gestation, irrespective of the presentation, if there is a difficult labor or a difficult delivery, that can be a risk factor in itself, and preterm babies or breech presentation at birth between 28 weeks to term. Other risk factors are these, like oligohydramnias, large for gestational age, prematurity, multiple pregnancies, and congenital calcaneovalgus foot deformity. So we assess the hip, look at the symmetry of the leg length and the leg creases, level of the knees when the hip and the knees are flexed, and restricted abduction of the hip flexion. Once we have done that, we do the Barlow and the Ortolani examination. I thought I'd better show a video rather than me talking. It's better to see how it's done. Let's see if it plays.
How to Test for Newborn Hip Dysplasia by Dr. Nina Gold. You will now assess the infant's hips to test for hip dysplasia. Hip dysplasia is a congenital deformation or misalignment of the hip joint and is more common in infants who have a family history of hip dysplasia, are female, or who had a breech presentation in utero. Assess the hips one at a time using 2 maneuvers. In the Barlow maneuver, first adduct the hip by bringing the thigh toward the midline. Then apply a gentle posterior pressure to the knee. In the Ortolani maneuver, flex the infant's knees to a 90-degree position. Then abduct the legs by folding the thigh outwards.
So we've seen what the Barlow's and the Ortolani test, how we do it. So Barlow's identifies which hip is dislocatable. The positive test causes the femoral head to slip out of the acetabulum, which you can feel when you're doing the examination. In Ortolani's, it confirms the diagnosis and identifies the hip which are dislocated. So if it is dislocated, you can sometimes feel a clunk when the femoral head goes back into the acetabulum during abduction. Once we've done the screening test, how do we refer and when do we refer? So if there are risk factors at newborn check, they are referred and they have an ultrasound scan at 6 weeks of age. If any of the maneuvers or we have a positive clinical finding, they are referred and they get a scan within 2 weeks of age. If it is found at 6 to 8 week check to have Ortolani positive, you refer them urgently to pediatric orthopedic surgeon, and they get a review at 10 weeks of age, maybe so just after 2 weeks of it being found out on examination. Now moving on from, so we've done the eyes, we've done the heart, we've done the hips, now we're down to the testes. This is an 8-week-old baby boy who's attended for the postnatal examination in a GP practice, and you are the FY2. This baby has been allocated to you for a postnatal check. This baby boy had a unilateral undescended testis at newborn examination. The parents are really concerned. You do the postnatal examination and you find that the testis is still undescended. What should you do next? Just pop the answers in the chat box. Absolutely right, it's B. Okay. So genital assessment, you observe for the symmetry, size, and color. Then you palpate the scrotal sac to locate for the testes. If you feel the test is bilateral, fine. If you can't, go up to the inguinal canal and try and milk it down towards the scrotal sac. Sometimes on milking, you can feel the testicles high up. And another thing to keep in mind is when you undress the infant, and if the room is cold, the testicles can retract a bit. So just be wary to keep the room warm when you're doing a postnatal examination. Otherwise, it can give a misleading examination finding. So once we've done the screening, in the newborn examination, if both the testicles are undescended, they are seen within 24 hours by the pediatric surgeon. We need to rule out metabolic and disorder of sex development condition. If there is a unilateral undescended testis, the GP or the primary care has to review at postnatal check. Once at the 6 to 8 week check, if you still find bilateral undescended testes, it's an urgent referral to pediatric surgeon and they get seen within 2 weeks. Persistent unilateral undescended testes, you got to bring them back at 4 to 5 months of age and refer no later than 6 months. So there's some common infant conditions. Put the diagnosis in the chat box. So what is this? Very common in the picked up normally at the neonatal check. I did have a newborn yesterday who had a unilateral condition, but somehow got missed out at the neonatal examination. Okay, let me just see. So yeah, that's perfect. Yeah, it is talipes. What about this one? My slide just moves trying to get the chat box up. Can't see. Okay, yeah, let me see what. That's right, Nabila, that it is syndactyly. For some reason, syndactyly is, it runs in family. So if you find out to speak to mom, there will be a family history. What about this? Polydactyly, absolutely, yes. And polydactyly too has a family history, does run in family too. What about this? Focus on this. Yes, it's single palmar crease, perfect, yes. So this will be picked up at the newborn check. Once you find a single palmar crease, look for other signs of Downs, get your registrar to have a look. In fact, the registrar will get the consultant to have a look as well because it's a significant diagnosis for a newborn. Some common skin conditions in the infants. Can anyone write what this is? Just a couple of maculopapular rashes on the cheek. Lost the chat box again. So this is infantile acne, which is due to the maternal hormones being passed on to the newborn. You just have to reassure it does settle down, resolve on its own. What about this? Milia, perfect, yes. Okay. Moving on. What can we see here? Mongolian spots, absolutely. So these are quite common. The only thing you have to be really careful about the Mongolian spots is ensure you make an entry about the size, the location, the color in the red book, and also the electronic system. It's just that it prevents any hassle to the family and the child as they grow older, because it can be misdiagnosed with something else if there is no entry made at the newborn or the postnatal check. So just document Mongolian spot, where it is, what color it was, which is relevant as the child grows up and for the family as well. What about this? Yes, capillary hemangioma does resolve by first birthday. And only thing you need to tell mom, if it's growing bigger, if it's bleeding, to seek medical attention. Any idea about this? Yes, Megan, put Weinstein, absolutely. Again, we have to tell that it will self-resolve, but if it's involving the eye, then you have to refer to the ophthalmologists. What about this? This is just erythema toxicum neonatorum. We just reassure the parents it's a baby rash. It will resolve in a couple of days. No action needed. What do we have here now? Yes, a cradle cap. Doesn't, yes, it's quite severe to be honest. And you can either advise coconut oil or Capillary shampoo, and it does clear away really quickly. What do we have here? Perfect, yes, umbilical hernia. And just reassure mom, in olden days, they used to do, say, a peak coin, press it on, tie it with a piece of cloth, and it will get better. We don't do that anymore. All we do is ask mom to make sure that the child is not crying a lot. And if it's not soft, not reducible, then she needs to go to A&E. For development, review the weight, growth chart, hearing and vision, startling, fixing and following, social smile, and cooing. These are some of the health promotion that you do. It's just listed. Remember the health visitor. She is a very good tool and she supports the mom in most of the things. Pick up on dangers of passive smoking. Just have an opportunistic smoking cessation advice if relevant. We need to look into the maternal health as well, both mental, physical, well-being, safety, domestic abuse. This will be picked up by the health visitor. 30% of the domestic abuse starts during pregnancy. Just to ensure you ask about how the baby was delivered, any worries about the baby, any worries about her own health. If mood an issue, then Edinburgh Postnatal Depression score. Ask about the perineum, LSCS scar, any pain, and whether the lochia is normal or periods have resumed, any incontinence, whether breastfeeding, if yes, encourage. Just a few of the maternal examination, palpate abdomen to look for retained products of contraception, endometritis, blood pressure if it was high, VE only if there's all these conditions. Smear is delayed for 3 months. Check for hemoglobin if anemia, and they need a fasting plasma glucose if gestational diabetes, which is done between 6 to 13 weeks, and then they have an annual A1C. The common mental health condition, baby blues, very common, 3 to 10 days after childbirth, and no treatment needed, gets better on its own. Postnatal depression, as we discussed, Edinburgh Postnatal Depression score, 1 in 10 moms from 4 weeks up to several months. Pharmacological therapy, CBT or interpersonal therapy, some evidence of exercise. Postnatal psychosis is uncommon. 1 in 1,000 mom needs urgent referral to psychiatry. So just be careful about this. A lot of about contraception and postnatal period is quite extensive. I'll be sharing my slides so you can know when to start which one when they seek advice, and similarly further on the contraception. Lactational amenorrhea is 98% effective if fully breastfed, amenorrheic, and babies less than 6 months old. This is just the clinical tip: heart, eyes, testes, hips. We discussed all of those. 8-week-old child, which of the following milestone is appropriate regarding hearing? So they respond to loud noises and turn to sounds. They all get a hearing test at birth. You can have a read about this. 1 test, if unresponsive, they get a 2nd test. Newborn blood spot screening done on day 5 to 8 by the midwife, Guthrie test. And these are the conditions that we screen for. This is just a flow chart of what we've spoken about in terms of the neonatal and infant physical screening pathways. And this is a very good Public Health England flow chart from preconception to antenatal to newborn, as a very good document for the midwives and for the neonatal and the postnatal examination. Some of the references, and don't forget the Red Book. And thank you for your patient listening.